Good afternoon. I am Dr. Ignacio Montaño. I would like to sincerely thank the organizing committee for inviting me to take part in the annual Echocardiography and Cardiac Imaging course organized by the Chilean Society of Cardiology and Cardiovascular Surgery. The topic I have to present is the three vessel and trachea view in the fetus, its advantages and disadvantages. The roadmap, advantages, key points for diagnostic suspicion, evaluation of the thymus and vascular structures, the disadvantages, and lastly, the conclusions. The three-vessel view is an axial plane of the fetal chest located just above the four-chamber view, and it is obtained through a sequential sweep starting at the right ventricular outflow tract, where we will evaluate the pulmonary artery, the ascending aorta, and the right superior vena cava. An oblique section of the pulmonary artery and a cross-sectional section of the aorta and the vena cava. The pulmonary artery continues with the ductus arteriosus. The three-vessel trachea view describes the most cephalic image, where we will evaluate from left to right the ductal arch, the transverse aortic arch, the vena cava, and the trachea. The trachea is located to the right of the ductal arch and the transverse aortic arch, and the trachea will be seen with a hyperechoic ring that is surrounded by an anechoic halo, which is an echo-negative image, which is fluid when the fetus is in inspiration. Under normal conditions, there must be anterograde flow in both arches, flow of the same color. The three-vessel trachea view will allow us to visualize both arches in most fetal positions and detect many anomalies in the outflow tract. The advantages, it will allow us to identify the transverse aortic arch and assess the laterality of the arch. Under normal conditions, the aortic arch has to be to the left of the trachea. Assess the calibers and diameters of both arches, the ductal and aortic arches, and detect many conotroncal and ductal lesions. A little more toward the cephalad direction, other vascular structures can be easily identified, such as the brachiocephalic or innominate vein, which drains into the superior vena cava. And here on the right, we see the azygos vein, which also drains at the level of the superior vena cava. We can apply color Doppler in the three-vessel trachea view, and we always have to evaluate here that when the spine is anterior, we are going to assess antegrade flow in the ductal arch and in the aortic arch, and when the spine is posterior, antegrade flow in both. Here we see in grayscale and color Doppler from left to right, the ductal arch, the transverse aortic arch, the vena cava, and the trachea. Antegrade flow in both the ductal arch and the aortic arch. Always from left to right, the ductal arch, the transverse aortic arch, the vena cava, and the trachea. Another advantage of the three-vessel trachea view is that it will allow us to easily evaluate the ductus arteriosus and the aortic isthmus. And it should be evaluated at the convergence of the V. We place the cursor at the level of the convergence of the V, and we are going to evaluate the ductus arteriosus here. And at the distal level of the transverse arch, before the convergence of the V, before the junction with the descending aorta, we are going to evaluate the aortic isthmus. Here we are evaluating the aortic isthmus, which has a normal morphological waveform, has a systolic velocity that in this case does not exceed 100 centimeters per second, and has a diastolic velocity present. Evaluating the aortic isthmus at the convergence of the V before the junction with the descending aorta. Evaluating here on the left, the ductus arteriosus, and here on the right, we evaluate the aortic isthmus, which has its systolic flow and its diastolic flow present. What are the key clues for diagnostic suspicion on the three-vessel trachea view? We can evaluate the number of abnormal vessels, normal vessel alignment, normal vessel size, abnormal flows, arch position, reverse flows, turbulent flows, and aberrant vessels. We're going to start with the normal size of the vessels. In this case, we see a three-vessel trachea view. Here we see the ductal arch, which has a larger diameter in relation to the transverse aortic arch. The transverse aortic arch is smaller in diameter, but it still has antegrade flow. We can immediately suspect that we are dealing with a ductus-dependent heart disease, which would raise suspicion of an aortic coarctation. This one had an aortic isthmus of 2.3 millimeters, which gave a z-score of 2.8. The newborn underwent an echocardiogram and it was confirmed to be a coarctation of the aorta, and surgery was performed at 10 days of age. Another case of abnormal vessel size, very similar to the previous case. We see a transverse aortic arch with a smaller diameter. There was even reverse flow at the level of the aortic isthmus. There you can see that the transverse aortic arch has a smaller diameter and there is turbulent flow within it. This is a critical aortic coarctation. The diagnosis of an aortic coarctation was also confirmed as well. Now we are going to evaluate the best predictor for assessing aortic coarctation is at the level of the aortic isthmus, and mainly the relationship that exists between the aortic isthmus and the ductus arteriosus. This ratio between the aortic isthmus and the ductus arteriosus has to be greater than 0.78. That is normal. When this ratio is less than 0.78, then there is a high probability of aortic coarctation. Abnormal vessel size and turbulent flow. In the 3-vessel trachea view from left to right, we see a ductal arch of smaller diameter. We see the pencil tip sign, and there is also turbulent flow at the level of the ductus arteriosus. So we are in a condition that would be a restrictive ductus arteriosus, where there is a pulsatility index less than 2, a systolic velocity greater than 140 centimeters per second, and a maximum diastolic velocity greater than 35 centimeters per second. The waveform morphology in this case is altered, as we can see here. Another similar case, normal-sized vessels and turbulent flows at the level of the ductus arteriosus. Once again, we see another pregnant patient who had a fetus with a restrictive ductus arteriosus, and this was caused by the use of NSAIDs after 30 weeks. There can also be restrictive ductus arteriosus due to the use of polyphenols, such as green tea and mate, and there may also be idiopathic causes. Abnormal vessel size. When we are faced with this condition, we evaluate the dilated pulmonary branches. And here we can evaluate and confirm that the pulmonary valve is rudimentary, hypoplastic, or even agenetic. We are facing a condition that is the Fallot-complex, and this is going to give us an abnormal size of the vessels, especially the pulmonary branches, which will be completely dilated, as well as the pulmonary trunk. When applying color Doppler, there will be stenosis and insufficiency. The blood flow will go toward the lungs and will return, and it will dilate the pulmonary branches. In this case, there is agenesis of the ductus arteriosus. The flow reverses, dilates the pulmonary branches, will dilate the pulmonary trunk, will dilate the right heart chambers, will cause cardiomegaly, and may even lead to hydrops and fetal demise. This condition has been associated with DiGeorge syndrome, and it comes from the abbreviation of the English acronym CATCH22, in which there will be a cardiac defect, facial anomalies, thymic hypoplasia, cleft palate, hypocalcemia, and deletion of chromosome 22q11. Abnormal vessel size. From left to right, we see the pulmonary artery, aorta, and vena cava. What stands out is that the pulmonary diameter is decreased in relation to the transverse aortic arch. Therefore, we are going to suspect that we are facing a condition that is a Fallot-complex of the pulmonary valve stenosis type. And when we do all the inferior views, we see here that there is a ventricular septal defect with aortic override. When applying color Doppler at the pulmonary level, it has an increased systolic velocity greater than 100 cm/sec for a 25-week pregnancy. So, a Fallot-complex type of pulmonary valve stenosis, abnormal vessel size, and lack of continuity of the transverse aortic arch. Here we can see from left to right the wide ductal arch, the transverse aortic arch that is interrupted, and here we see the vena cava. Therefore, we are facing a condition, a left ductus-dependent congenital heart disease, which would be an interruption of the aortic arch, in this case type B. Here we can see from left to right the ductal arch, and at the level of the transverse aortic arch on color Doppler, there is flow only at the level of the proximal portion. The distal portion is not visible because it is interrupted. We are facing a left ductus-dependent congenital heart disease, interrupted aortic arch type B. Another example from another patient, same. Here you can see the wide ductal arch. Of the aortic arch, only the ascending aorta is seen. The transverse aortic arch is not seen. When we evaluate the outflow tracts here, we will also see that there is an abnormal size of the vessels. Notice that the pulmonary artery is quite dilated. The aorta has a smaller diameter and almost the same diameter as the vena cava, and the aortic arch is interrupted. When we evaluate the lower views, we are going to see a subaortic VSD and an ascending aorta with a more vertical course. In 2015, we published a clinical series of 3 cases of type B interrupted aortic arch. And the view that indicated we were facing an interruption of the aortic arch was the 3-vessel trachea view, where there was a lack of continuity of the transverse aortic arch. This is a surgery for a type B interruption of the aortic arch. Here you can see an interrupted arch, the pulmonary artery well dilated, large in relation to the ascending aorta, which is of smaller diameter, and the interruption between the left carotid and the left subclavian artery. An anatomical specimen of a type B aortic arch interruption. The interruption is between the left carotid artery and the left subclavian artery. Abnormal number of vessels, 4 vessels in the 3-vessel tracheal view. When we evaluate a 4th vessel to the left of the pulmonary artery, we will immediately suspect that it is a persistent left superior vena cava. And this occurs in 1 out of 300 people. The left superior vena cava will connect to the coronary sinus, which will drain into the right atrium, and this 4th vessel will be visualized to the left of the pulmonary artery. We will see the 4th vessel, the pulmonary artery, the aorta, and the vena cava, which would be the persistence of the left superior vena cava. The left superior vena cava can occur in isolation. It can occur when there is left obstructive heart disease, an atrioventricular defect, or a conotruncal heart disease. For example, persistent left superior vena cava, we can see to the left of the pulmonary artery, the persistent left superior vena cava can be seen, or the same case, persistent left superior vena cava, applying color Doppler, the persistent left superior vena cava can be seen here. And when there is a persistent left superior vena cava, we are also going to assess whether the superior vena cava is going to be normal in size or smaller. And in the 4-chamber view, an echo-negative image at the level of the lateral wall of the left atrium must be evaluated in order to make the differential diagnosis from another condition that will also show 4 vessels in the 3-vessel trachea view. We see the left superior vena cava in the left atrium. Another condition in which we are going to see 4 vessels on the 3-vessel trachea view, and it is the differential diagnosis of a persistent left superior vena cava. Take a look. Here we see 4 vessels in the 3-vessel trachea view. Right away, we can suspect that we're dealing with a persistent left superior vena cava, but what stands out here is that the right superior vena cava is more dilated. Therefore, in this case, it is a supracardiac anomalous pulmonary venous drainage, and this patient had 4 vessels on the 3-vessel trachea view. She had a single umbilical artery. And what drew attention was this vessel to the left of the pulmonary artery, but this vessel corresponds to the vertical vein, a vertical vein that through the brachiocephalic vein will drain at the level of the right superior vena cava. The diagnosis is a supracardiac anomalous pulmonary venous drainage, such that it is a differential diagnosis with a persistent left superior vena cava, which will also show us 4 vessels in the 3-vessel trachea view. But the difference is that the right superior vena cava is going to be dilated. Abnormal number of vessels, 2 vessels in the 3-vessel trachea view. When we evaluate the 3-vessel view with only 2 vessels, we see the transverse aortic arch, the vena cava, and the trachea. We are dealing with a conotruncal heart defect, which would be a transposition of the great arteries. We see the transverse aortic arch, the vena cava, and the trachea. We don't see the pulmonary artery because it is posterior and inferior, because the vessels are transposed in such a way that we see the aorta anteriorly and the pulmonary artery posteriorly. In the 3VT view, we see the transverse aortic arch, the vena cava, the trachea, and the pulmonary artery is posterior. This is the skateboard sign where we see the transverse aortic arch, the vena cava, and the trachea. 2 vessels in the view, 3 vessels trachea. We can also see this in another condition, in another conotruncal heart defect, which is Dorvey of the transposition of the great arteries type, where we will see the same thing. Here in this case, Dorvey of the transposition of the great arteries type, we see the transverse aortic arch, the vena cava, and we are also going to see 2 vessels in the 3-vessel and trachea view in another conotruncal heart defect, which is truncus arteriosus. We'll see a dilated, large transverse aortic arch, the vena cava and the trachea. No, in this case, the ductal arch is seen because this heart defect is associated with agenesis of the ductus arteriosus. Arterial trunk, 2 vessels in the 3-vessel trachea view. We see reverse flow in the ductal arch. there is retrograde flow in the ductal arch and antegrade flow in the aortic arch. This is a right-sided ductus-dependent congenital heart disease, a complex fallout of the pulmonary atresia type. For example, another heart disease, pulmonary atresia with an intact septum, reverse flow in the ductal arch. Reverse flow in the aortic arch. Here we see that there is reverse flow in the aortic arch and antegrade flow in the ductal arch. We are dealing with a left ductus-dependent congenital heart disease, a critical aortic stenosis, where we are going to see reverse flow in the aortic arch. Left-sided ductus-dependent heart disease, a wide ductal arch that is like a cannon, and a hypoplastic aortic arch of smaller diameter with reversed flow. And we are facing a condition that would be hypoplastic left ventricle syndrome, where reverse flow will exist in the aortic arch. Another example, reverse flow in the aortic arch. Likewise, in a left ventricular hypoplasia syndrome, where it is clearly seen that reverse flow exists in the aortic arch. Abnormal position of the arch. When we come across this image in the three-vessel trachea view from left to right, the ductal arch, the trachea, the aortic arch. To the right of the trachea, we are looking at an aortic arch on the right, and the V image on the three-vessel trachea view will be replaced by a U. And here we can see from left to right the ductal arch, the trachea, and the transverse aortic arch. The trachea is between the ductus arteriosus and the isthmus. The aortic arch on the right is associated with an aberrant left subclavian artery. A right-sided aortic arch can produce vascular rings due to compression of the trachea and the esophagus. And there is another condition that in the second trimester can be interpreted as a right aortic arch, but it is actually a double aortic arch. And here we can see from left to right, the ductal arch, the left aortic arch with a smaller diameter or hypoplastic, and the right aortic arch, and also the trachea. The trachea is located between the two arches. In the notch, the trachea is located. This produces vascular rings due to compression of the respiratory and digestive tract. Double aortic arch, we see here the ductal arch, the hypoplastic left aortic arch, and the right aortic arch, and the trachea in between the two arches. Again here, from left to right for better understanding, double aortic arch, pulmonary artery, ductal arch, hypoplastic left aortic arch, right aortic arch, and the trachea. The right aortic arch, but mainly the double aortic arch, produce vascular rings due to compression of the trachea and the esophagus. It can cause respiratory symptoms, inspiratory stridor, a hoarse cough, respiratory infections, and in 1/3 of cases, Lusoria dysphagia. The vascular ring, as I mentioned, is formed by the two aortic arches and is associated with chromosomal abnormalities, including 22q11, in 2% to 20%. It can present in isolation, or it can be associated with complex congenital heart disease. In the year 2020, we published a clinical series of 4 cases of the three-vessel trachea view in the detection of vascular rings. Just so you can see, of the 2 developed vascular rings and 2 underwent surgical correction, and the other 2 were also associated with DiGeorge syndrome. Aberrant vessels. When a vessel emerges from the distal part of the three-vessel trachea view, from the distal portion of the transverse aortic arch, and passes behind the trachea toward the right arm, we are dealing with a condition that would be an aberrant right subclavian artery. You can see that at the level of the isthmus, a vessel emerges and passes behind the trachea. In a straight line, it goes toward the right arm. This is the aberrant right subclavian artery, which arises from the distal part of the transverse aortic arch. It occurs in 1 to 2% of normal people. Its incidence increases in Down syndrome by 10 to 20%, but not only in Down syndrome, but also in other chromosomal abnormalities. It is an important marker of chromosomal abnormalities. We were dealing with a Fallot complex, and it had an aberrant right subclavian artery. You can see that the subclavian artery passes behind the trachea toward the right arm, and it is important to lower the PRF to less than 20 centimetres for evaluation, so that you can visualize it in the three-vessel trachea view. A karyotype was performed for this patient, and it turned out to be trisomy 18. She decided on either we can evaluate the thymus in the three-vessel trachea view, and the thymus is a structure that is located behind the sternum and above the great arteries. The thymus is a structure that on ultrasound appears more hypoechoic than the lung, which is more refringent. We can assess the size of the thymus. And by applying this method, we can more accurately assess the size of the thymus. Here, the thymus can be clearly seen to assess its size using a Thymic-to-thoracic ratio that was proposed by Cowie. For this, you need to measure from the posterior part of the sternum to the anterior part of the vertebra to measure the mediastinum, and to measure the size of the thymus from the posterior part of the sternum to the anterior border of the great arteries. And this ratio always has to be greater than 0.44. When this ratio is less than 0.3, we are faced with suspicion of thymic hypoplasia, which has been associated with conotruncal heart defects and also with heart defects, mainly those associated with deletion of chromosome 22q11, as well as chromosomal abnormalities such as trisomy 21 and trisomy 18. We can also evaluate the size of the thymus with the thymic box to assess the presence of the thymus. And when applying color Doppler, we are going to see that the internal mammary arteries are laterally located and the base is defined by the brachiocephalic vein. The three-vessel trachea view is part of the 5 views proposed by Yagal. According to ISUOG recommendations, the outflow tracts and the three-vessel view and the three-vessel trachea view should be integrated into the evaluation of the heart in the second trimester ultrasound. The three-vessel view and the 3VT are the last views of the superior mediastinum among Yagel's 5 views, and as I mentioned, they are part of a sequential sweep of the right ventricular outflow tract, the three-vessel view, and the three-vessel trachea view. So, we are going to evaluate transverse sections that start at the level of the upper abdomen to reach the upper mediastinum and assess the three-vessel view and the three-vessel and trachea view. In conclusion, we can say that the 3VT view provides information that will allow the detection of conotruncal abnormalities and ductus-dependent lesions. Most of these disorders are associated with an abnormal 3VT view. It helps reduce neonatal morbidity and mortality. The three-vessel trachea view is generally easy to obtain across all gestational ages, including in the first trimester. Here we can see a three-vessel trachea view in a 13-week pregnancy. Once again, this is a normal three-vessel trachea view in a 13-week pregnancy. Sensitivity increases with the use of color Doppler, which helps detect atresia of the great vessels and the progression of flow-related abnormalities, such as acquired stenosis. Additional vascular features, such as malformations of the brachiocephalic vein and the azygos vein, can also be identified using the three-vessel trachea view in a slightly more cephalad plane. The three-vessel trachea view also plays a very fundamental role in the detection of vascular rings, thereby enabling early follow-up and appropriate treatment of these newborns and preventing the digestive and respiratory complications that vascular rings can cause. Finally, the thymus gland can be carefully evaluated, which may be absent or may be hypoplastic in the setting of a conotruncal disease and the 22q11.2 deletion or another chromosomal abnormality. Finally, we want to say that there is no disadvantage. State categorically that the three-vessel tracheal incision has no disadvantage. Thank you very much for your kind attention. I want to thank my national professors and my international professors, and above all, to thank you for being my very good friends. Thank you all very much for your kind attention. See you at the round table. Thanks very much.